Good morning, everybody. I really want to thank the organizers for inviting me to Australia. One of the things I was thinking of, as I show my disclosures, in preparing this talk is that it's always difficult to speak about the future. And, physicists in the past have said that predictions are difficult in general, but especially when you talk about the future. And I've also been very concerned about talking about the future because I always seen that in the past some of my mentors have given these lectures towards the end of their career. I still believe I'm relatively young, or at least I hope so. I think what is important to say is that we don't know exactly what the future holds, but we could anticipate some of the developments as long as we try to understand that new knowledge requires change in mindsets, and that is important even before we can start practicing a coherent change in what is clinical practice or research in the areas of diabetes. And I think what surgery really has to give to us is, at this moment, I really believed from the very, very first moment I got involved into this field, is that new surgery can give us a new way of looking at diabetes and obesity. I had no interest whatsoever when I was a surgical resident to become a bariatric surgeon. But everything changed when I realized that, by looking at this surgery, you could actually change potentially the way you conceive and treat diseases that are so important today. But I want to start by telling you how it is also time to think differently about surgery and why this is and what the potential is if we do so. So first of all, there was a beautiful lecture by Randy Seeley this morning about how surgery works, and I think he makes my job very easy here, because in one slide only I can say that thinking about surgery as a mechanical intervention is just inconsistent with not only the evidence of many mechanisms being at play beyond restriction or malabsorption, but also with the logic that itself. Because if the gut is as it is, a very crucial organ in physiologic regulation of metabolism, then changing the anatomy of this organ is inevitably going to change that physiology, inevitably going to change a number of things. So assuming that we're just restricting intake of food per se mechanically or absorption is really naive. I think that is true not only for effects on diabetes, but also for effect on weight regulation. Now, as you understand that mechanism, then everything changed in the way we look at bariatric metabolic surgery, because it's no longer, as I say, an intervention that deals with intake of energy, whether at the level of food intake or food absorption, nutrients absorption. But it's actually a physiologic, bariatric surgery or metabolic surgery is a physiologic approach to changing the metabolism, the biological mechanism behind metabolic regulation and weight regulation, etc. So with that in mind, you can think of metabolic surgery as an umbrella definition for the application of gastrointestinal interventions for the treatment of different types of disease, which might also be considered collectively as metabolic diseases. So one example is diabetes surgery. Another example is surgery for, of course, which we have done for many, many years, for extreme obesity. In that case, the goal of surgery is to treat the consequences of being extremely heavy just in it by itself. And there would be, many examples of this, including patients who, for instance, cannot have a renal transplant because they're too heavy. So doing bariatric surgery for the sake of inducing weight loss has a purpose there. But treating diabetes or treating other diseases per se may also be an application of these operations. And we'll talk more about diabetes surgery, but I just want to highlight the potential of this surgery to treat other diseases that we never considered before, such as partial familial lipodystrophy. This is a case of a patient that was referred to me in London by colleagues at the University of Cambridge in the UK, where they have a national center for the study of lipodystrophy. This patient had a BMI of 26, so was non-eligible for bariatric surgery by any criteria, neither NICE or NHS criteria or local CCGs, etc., But she was diabetic, as you would predict in people who have familial lipodystrophy, with very relatively low BMI, but high insulin resistance, very severe diabetes, on insulin treatment. This patient was, of course, refused by NHS for potential consideration of bariatric surgery, but she was a lawyer, and she made a fight for over the years to make the case that because she had no other options, her diabetes was poorly controlled, there was an intervention that has been demonstrated to improve insulin sensitivity, why she should not have access to this treatment. The bottom line is that thanks to the colleagues in Cambridge and her own resilience, she was able to obtain individual coverage for surgery in her case, just regardless of BMI 26. So we did the operation on a Friday afternoon, and this patient walked out of the hospital on Monday morning with no signs of hyperglycemia and completely off insulin. Now, this is familial lipodystrophy. Again, it's not a typical form of type 2 diabetes, but I think here is another potential use of the surgery, again, for diseases that have not been considered before. I think if we want to be coherent with what we're seeing in terms of mechanistic knowledge and how we translate this in clinical practice, we need to understand that also using surgery for treating metabolic diseases, whether it's lipodystrophy or NASH or diabetes itself, entails a number of implications. A lot of people say, well, what are you talking about? You're still using the same operations. Why you call it metabolic surgery? It's a rebranding of bariatric surgery. At the end of the day, you use the same gastric bypass or sleeve gastrectomy, etc., whether you treat diabetes or whether you treat morbid obesity. And I argue with that because I don't think that's a good reason why there should be no distinction between bariatric surgery and diabetes surgery. In fact, there is this common misperception that if you want to define metabolic surgery, you should consider only metabolic surgery when you're using novel procedures or not the conventional traditional bariatric procedures, or when you're doing this in low BMI patients. Both of these ideas are complete misconceptions, I believe, because metabolic surgery is not defined, or diabetes surgery is not defined by the procedure nor by the BMI level, but by the intent or the disease you intend to treat. And to give you a sense of this happens in surgery all the time. We use the same operation to treat ulcers or cancer in the stomach, but it's not the same thing. If you treat cancer, it's cancer surgery. If you treat ulcers, it's a different type of surgery. You can use colectomies to treat cancer, to treat inflammatory bowel disease. It's the same operation, but it's entirely different from a clinical practice standpoint, for all the implications that are there. And again, it's not a procedure. Now, people understand this in the medical field much better than surgeons do, because physicians are used to use drugs with different purposes. Many drugs have been repurposed over the course of history from one disease to another. And as you do that, of course, everything changes. Now, aspirin obviously has been repurposed from the treatment of fever and pain into cardiovascular disease treatment, but also liraglutide to be closer to our field. You can use drugs like GLP-1 agonists as a diabetes intervention or as a weight loss intervention. In fact, they are so much different that they are used in different situations or in different moments of the algorithm of management, but also even insurers will cover the same drug for one purpose as opposed to another. So look at how many implications there are when you change the purpose of that intervention. So 2 years ago, we completed this diabetes surgery summit that has concluded with the development of some recommendations and guidelines specifically for the use of surgery as a diabetes therapy. And these recommendations are now endorsed by over 53 organizations from around the world. But a lot of scientific and lay media have hailed this development as a major change. The American Diabetes Association has even changed their standards of care to incorporate those recommendations. But a lot of media have actually hailed this as a major change in the way we will look and treat diabetes, but also look at diabetes, changing the landscape of diabetes care altogether, and some have even considered this to be such a radical change that it really almost parallels the introduction of insulin, conceptually, if you will, if also not practically. So surgery changes also, as I say, the way we look at diabetes. From practical point of view, changing the purpose of surgery means many things. You cannot say that bariatric surgery for weight loss is the same as diabetes surgery, because by changing the goal, you change the population you're operating on. And as a result, you change the criteria for surgery, the timing at which surgery should be used. The way you choose the surgical procedure is no more a random decision or a choice of the patient, but it should be personalized and individualized on patients' characteristics. The post-operative follow-up, the management pre-op, and also access to surgery changed dramatically and completely. There are different problems, there are different opportunities as you change the disease you want to treat. Just to give you an example, I can tell you that when we use surgery as a weight loss intervention, we need to be realistic about what are the patient's motivation for surgery. The majority of patients who are seeking surgery, who come forward, are the ones who feel excess weight is a problem for them. And for whatever reasons, there's maybe social, psychological reasons to be analyzed. I don't want to go in depth, but a study, I think it's here from Australia, shows that most people who almost 50% of people who do seek bariatric surgery admit to do that for a physical problem or a concern about their body image, as opposed to for medical reasons. I would submit that even in those 52% that declare medical reason, there might be many who might actually consider physical or appearance or cosmetic concerns more important. So this is important because when you when you look at the epidemiology of bariatric surgery, you see that is reflected. The reasons why people seek surgery is reflected in the demographics of our patients. In fact, the vast majority of patients who actually have or men patients, for instance, don't try to lose weight very often, and female surgeons do. So when it comes to bariatric surgery, you have very often this kind of female to male ratio that overwhelmingly shows a much greater prevalence of female patients in bariatric surgery as opposed to male patients. Also, interestingly, the prevalence of diabetes in traditional bariatric surgery has been below what you would expect for the same population. So we have been seeing a skewed population coming into bariatric surgery because the focus was a weight reduction therapy. This was supposed to be an obesity treatment or a weight reduction therapy. So in 2013, we published a paper after looking at our experience. I was at the time practicing in New York City, and we had a very unique kind of setting in our department of surgery. When I joined Cornell at the time, there was already an existing traditional bariatric surgery program, and I was recruited to develop what it was supposed to be a diabetes metabolic surgery center. And we went on and advertised or promoted the new program with GPs or PCPs, et cetera, and diabetologists, et cetera, as a treatment as a center where they could refer patients when they were concerned about either metabolic issues, sleep apnea or NASH, or diabetes, of course, and as a first thing. So this model allows us to really separate what would be the bariatric surgery population, typical bariatric surgery population, to what would be a metabolic surgery population. So in a way, this gives you a little bit of a glimpse into the future. As we will do more metabolic surgery, these are the type of patients you're going to see more often. And you can see here that there are more patients who are, there are older patients in metabolic surgery. There are more male patients coming forward, finally, because they do feel diabetes or metabolic syndromes are significant health problems. So when you say we want to treat this, they're going to come forward more often. We also see that each of the conditions that normally we see present in bariatric surgery are now more severe in metabolic surgery. We have people with more cardiovascular disease at baseline than we had in bariatric surgery, et cetera. So substantially, metabolic diabetes surgery changed the demographics and the clinical characteristics of the patient population. And so don't underestimate these potential changes, because this has a lot of implications for post-operative outcomes, perioperative management, integration of therapies, et cetera, et cetera. The criteria for selection of surgical candidates also change. This is the algorithm from the Diabetes Surgery Summit, now also recognized by the American Diabetes Association, and as I said, endorsed by 53 diabetes organizations, including, importantly, the Australian Diabetes Society. So, as you can see here, this is it may look like a baby step towards changing criteria, but it's, in my opinion, a fundamental difference compared to what we've done so far in bariatric surgery. This is an algorithm for the treatment of type 2 diabetes. This algorithm speaks to every provider that takes care of diabetes. Okay? So this is not speaking to patients who are obese and they're asking permission to have bariatric surgery. This is a way to treat diabetes. And the algorithm says if you're type 2 diabetic, you should receive a sort of screening for potential surgical indication. If you're non-obese, at the moment, despite of the fact we know that surgery can also help in those cases, the evidence, however, is not sufficient to recommend surgery as a standard of care. However, if you are obese, including mildly obese, you don't have to be severely obese. Even mildly obese patients might be candidates for surgical treatment of type 2 diabetes. And of course, as opposed to using BMI alone, unfortunately, we still have BMI in the picture, and I hope one day this will fall finally. But we are starting to mitigate the dominance of BMI by saying something that you would say in every other surgical discipline. What is the response to alternative options for the same disease? Before you go to surgery, you have to explore if other options are being successful or could be successful, etc. So here is a new concept. We are looking also at glycemic control. If glycemic control is good and you're mildly obese, you may or may not need necessarily to have surgery. But if your glycemic control is poor, well, what is the point, despite of the fact you're taking insulin or many other drugs, what is the point of going on and taking ineffective therapies when there is something that could potentially change the course of that disease? So as a result, the indication, as I said, because now we're starting to talk about diabetes, we're going to de-emphasize parameters and criteria that are not necessarily part of diabetes management. BMI, I don't think any diabetologist uses BMI to determine which drug to give to patients. And so BMI could be a piece of the puzzle, but not necessarily the most important. The timing of surgery, of course, is also important. We know that the duration of diabetes can make a difference. So when you make surgery, specifically a treatment for diabetes, I think this will push all of us, including regulators, to avoid these artificial barriers that we put in accessing bariatric surgery, because patients in many countries, I'm not sure about Australia, but certainly in the UK, have to go through a 12 months tier 3 treatment prior to having surgery covered. Now, there's no evidence that that's being beneficial whatsoever. There's evidence instead that could be detrimental. So, but because we're thinking to treat obesity, and obesity is not an immediate threat, this kind of attitudes are tolerated. When you start saying diabetes is a disease that progresses, and there is evidence that if you delay treatment, you can have less efficacy or less cost effectiveness of the treatment, I think all of a sudden, those attitudes, those policies will look inconsistent with the evidence and with the aim of what we're doing. So those will change as a result, and I believe this is also a glimpse into the future. I think we will see more meaningful use of surgery and more timely use of surgery. The choice of procedure, of course, these are the accepted procedure for diabetes surgery according to the Diabetes Surgery Summit. I just want to say one word about this because some of my colleague surgeons are concerned because they only see these 4 procedures and they say why there is no duodenal switch, why there is no one anastomosis gastric bypass. The reason is because when we did a consensus conference for diabetes surgery, we had to use the same methods that are used in consensus conference for diabetes care at large, and they used randomized clinical trials. So only surgical operations that have been compared to standard of treatments made the cutoff for being recognized as diabetes interventions. And so, of course, the door is open for the future for other interventions to become accepted, but at the moment, we only know how these 4 operations would perform or outperform, as they do, other diabetes therapies. The conclusion of the DSS was that gastric bypass could be the one operation that has the best risk-to-benefit ratio in most patients, but that doesn't mean that it's the only operation that should be used for diabetes. And again, perhaps there is an opportunity to personalized or individualized choice of the procedure, depending on patients' characteristics, severity of disease, and other considerations. So this is also a glimpse into the future. Unfortunately, in bariatric surgery, the choice of the procedure is too often being determined by whether a surgeon was or not able to perform other alternative operations, or whether the patient had a preference for one or another because one of their family members had sleeve gastrectomy. I want to have a sleeve gastrectomy. I think this is unacceptable, would be unacceptable in cancer. You don't do a bypass or a sleeve, you don't do a total gastrectomy or partial gastrectomy based on preference. You will have to choose depending on where the cancer is located and so forth. And I hope that we will normalize our thinking on how to use this surgery based on disease severity and other considerations that are more meaningful. Novel interventions into the future, of course, there are some already under clinical trials and endoluminal approaches. I will not talk about those, but just to say that, of course, these are another consequences of our appreciation that the gut is an endocrine metabolic organ, and interfering with the gut physiology can actually exert effects on diabetes or obesity, and therefore there will be more of those to come, I believe, in the future. But the management, pre-operative and post-operative changes and effective changes in the disease you want to treat, obviously, the multidisciplinary teams and expertise involved as to broaden in order to be able to treat diseases that we're not historically used to treat, like, again, type 2 diabetes. And then I also want to conclude about access to surgery, because this is important, just to give you a sense of how shifting the focus of your surgical treatment will also have implication on access to surgery. For many years, we've been using or producing bariatric surgery guidelines. Those bariatric surgery guidelines are guidelines for the treatment of severe obesity. And who do they speak to? To a very small, unfortunately, and here there are many of you, but if you go out of here, there are not so many, unfortunately, physicians or surgeons who are visionary about the treatment of obesity. They know that obesity needs to be treated. But unfortunately, the rest of the world doesn't treat obesity. GPs don't treat obesity. A lot of other physicians don't treat obesity. They don't even consider our guidelines. When you speak about diabetes guidelines, therefore the new Diabetes Surgery Summit guidelines, you are talking all of a sudden to a much broader audience, a much broader number of providers. All GPs that treat diabetes need to be aware of these guidelines. All the endocrinologists who treat diabetes need to be aware of these guidelines. There is no justification in 2017 for not knowing that surgery is an option. I think very soon it will become malpractice. And so I want to just say, concluding my speech, with the fact that I don't know what the future really holds. What I think is important is that the present is already much different than the past. And if you're able to accept the need to change our mindsets and understand the difference between weight intervention, focus intervention, and disease-based interventions, I think we'll do much better service to our patients, and we'll have much more chances to be understood and by regulators, and patients might have more chances to get access to treatment. Thank you very much.